Good afternoon, everybody. This is our weekly COVID webinar. And we'll get started in just a second. Okay, so something new for this week is that you can get CME credit for watching this webinar live. And I put instructions in the Q&A part, but basically you just have to ask a question. In the name section, put your A or D number, and then in the question, just put CME. If you have an Allina email, you don't have to put in your email. If you do not have an Allina email, please put in the email that you want your CME certificate to be sent to. Unfortunately, we can't provide CME to people watching this for the recorded version, so it's only for the people who are watching it live. Okay, so today we have Dr. Rachel Lanasa, Dr. Dan Anderson with infectious diseases, and also we have Dr. Steve Bradley with cardiology, all here to present and then answer questions. So just like last time, we'll try to do the didactic content first. You can type your questions in as we go along so you don't forget them, but then we'll take all the questions and answer them at the end. And then there'll be a link with this recording that goes out this afternoon, and that's always on the AKN Provider Resources page under webinar. And then on Monday, we will have a Word document with the answers to the questions as well, and that will also be posted in the same place on the AKN so that you can we try to answer almost all the questions that come in. So with that, I will let Dr. Lanasa start.
All right. Hello, everybody. We are going to get started. We'll just kind of go over some topics that we're going to go over today. So first, Dr. Bradley is going to talk to us a little bit about some of the labs that can inform clinical trajectories and also modeling that was done by the state. We'll go over current epidemiology, we'll go over testing, we're going to go through a couple of cases. I'm going to talk a little bit about asymptomatic transmission because I know that's something that we've been getting a lot of questions about. Also some prognosis, going over kind of prognosis of critically ill COVID patients. We'll go over treatment again. We've gone over it a couple of times, but I think it's really useful. We'll talk a little bit about immunity and kind of where things stand as far as what we know about the immune response to COVID. And then we'll just comment quickly on kind of the universal masking that we are moving over to at Allina. So first, Dr. Bradley is going to talk a little bit. I'll hand it over to him.
Good afternoon. So first, I think it's worthwhile clarifying why a cardiologist is speaking to you about COVID. So my background is as a health services and outcomes researcher in quality improvement, and I'm within Allina and the Minneapolis Heart Institute. I'm part of the Healthcare Delivery Innovation Center, and we leverage Allina's vast data resources to identify opportunities to improve the quality and outcomes of care delivery. So we've expanded from cardiovascular disease, obviously, and we had been working within Allina in multiple service lines. And as COVID became the focus of everyone's appropriate attention, we were working to see how we, within the healthcare delivery innovation space, can help Allina provide the best care for our patients, both in anticipating both clinical trajectories for the individual patient and for the system to anticipate needs. So I'm going to share with you the work we've done thus far and how we continue to help provide that information both for our system and for individual patients. And then given that background, give some insights on models that are being used for modeling populations. So this is a bit of a review from last week. Our intent is to identify patients at high risk of clinical progression. So amongst patients who are hospitalized, who are those patients who are likely to progress to needs for ICU or invasive ventilation in the next 48 hours, both so that the system can anticipate needs in the next 48 hours and where patients may need to go, and so individual providers can anticipate those needs. From prior studies that are available in that prior webinar, there are studies that have identified risk factors for progression, demographics, predominantly older age, presenting symptoms, so fever severity appears to be important. Comorbidities, predominantly hypertension, diabetes, coronary disease, COPD, asthma, and potentially immunocompromised states. And then finally, certain laboratories. And what we're finding is that there are key laboratory markers that precede clinical decompensation, and you'll see I'll focus a lot on ferritin, as we're finding that seems to be amongst the strongest predictors of future decompensation. So our local experience to date, we have had 107 COVID positive patients within the line of health. 33 of those have been hospitalized. And in reviewing those 33 hospitalized patients, we do see that these markers tend to precede decompensation by about 36 hours. It's important to recognize that those markers are time dependent relative to symptom onset. So elevated markers within 4 to 10 days of symptom onset are more important than elevated markers about 10 days after. It's a little tricky to capture data on symptom onset, so this is requiring chart review at this point to inform that, but it's important as an individual provider to think about what is this level not only as an absolute, but relative to symptom onset. The other thing to keep in mind is that these markers are not diagnostic. Again, these markers are not diagnostic, they are prognostic. There have been patients who have been hospitalized for other conditions such as small bowel obstruction or malignancy with complications who have ferritin levels in the 4,000 to 5,000 range. Those patients have been COVID negative, and that marker is not diagnostic. Again, it's prognostic for the COVID positive patient. In looking at the 33 patients who have been hospitalized, 11 of those patients have required ICU admission, so 33%. And looking at specific markers, and these cutoffs have been defined based on trying to find the best sensitivity and specificity, you see that ferritin above 600 on admission was present in 9 of 10 patients who required ICU admission, and 2 of 15 who did not. Again, the timing of this laboratory is important. For the vast majority, this was 600 within 10 days. There are some patients, particularly those 2 out of 15, who had elevated ferritin even in the thousands range, but those were in the 11 to 14 days post symptom onset. Other markers appear to be less sensitive and specific, but can be helpful in weighing the balance of their prognosis, namely CRP, D-dimer, and absolute lymphocyte count. So tentatively, we're putting guidance together and thinking about what are the demographics and risk factors as well as their laboratories. We're working with Alina and folks within that have Excellion Access in terms of builds to try and provide this a way to the provider that they can think about what are the anticipated needs for this patient and what are the likelihood of clinical decompensation in the next 24 to 48 hours. I'll now move on to some discussion of the models that are being used for modeling populations. And I think it's important to recognize that these are all models, which means it's math, and the math is dependent on the inputs. And the challenge with COVID is a lot of these inputs are really somewhat unknown, and they vary as we continue to gain understanding. So there are 2 predominant model approaches. One is what's called a susceptible, infected, and recovered. Sometimes people include exposed in there. And essentially it models the population who are susceptible, the population that become infected, and those that recover over time. It's dependent on things like what is the infectivity rate. So if one person is infected, do they infect 2 additional people, 3 additional people? How quickly does that happen? What is the relationship in terms of how many people you come in contact with? You can model into that social distancing to try and estimate how much social distancing reduces the infectivity rate. And so one example of that type of model is on the left. This is the UPenn model. The link to that model is available on the left. You're welcome to play with it. You can put in, one of the ways to do is you can put in the population for Minnesota, which is 5.61 million. Assume that that's 100% of the population and do things like what's the doubling time, what's social distancing. You can see the impact of those things on the total number of hospitalized. One of the challenges of this model is that it assumes complete random association of people. So social distancing probably has effects on clusters. So you can imagine certain clusters of people, if you have an it may be reported I think it was 1 in 6 or 1 in 3 New York police officers are currently infected. That's a cluster of people who are not essentially social distancing and then have a lot of contact with each other. So it doesn't account for the lack of randomization in terms of how people come in contact with each other. The other model is coming from IHME. This is the model that was used by the White House in discussions earlier, I guess, this week. Time's weird. I can't keep track of time at this time of day. But this model is using, instead of estimates about the number of patients who are infected in the population based on the number of patients hospitalized, which is the way the UPenn model, they use the number of patients who die. So they argue that deaths are a more concrete outcome, and that if we model deaths relative to what we think is the infected rate, that they can get a better estimate of the projections. And then based on the rate of deaths over time, they draw a threshold at which they believe the rates of infection are declining. If you notice, the two different models have vastly different thresholds in terms of what they think is going to happen in coming days. So the UPenn model, which assumes complete random interaction with people, we'd have a total hospital census of over 20,000 patients in late May to early June, whereas the IHME Seattle model is very different. We'll only know with time which of these models is truly accurate, and obviously these are continually being revised over time, but wanted to provide you some insights about those models as you come across them in the lay press. I'll pass it back over at this time.
All right, thank you, Dr. Bradley. So we'll kind of start going through the current epidemiology of COVID-19. And so kind of start worldwide. So this is the Johns Hopkins dashboard. And so there are about 1 million cases confirmed across the world, and about 55,000 deaths. Confirmed cases, as you can see, the United States is number 1. And you can see the epi curve down below, which is still very steep. We'll move on to the United States. And so here we have the cumulative total number of COVID cases in the United States through April 1st. And once again, you can see that there is a still steep curve. There are an estimated 242,000 cases, and about 33,000 of those cases required hospitalization. And we are at about around 6,000 deaths in the United States. Once again, you know, seems mostly kind of in these hotspots, New York City, etc. In Minnesota, so here is our epi curve on the left, total number of confirmed cases, and you know, while definitely, you know, uptrending, definitely not as steep as, you know, the United States in general. Of the about 22,000 tests, we have about 742 positives. That gives us about a 3.7% positivity rate. 18 patients have died in Minnesota, and of the 742, it looks like there's about 138 cases that did require hospitalization. As of today, it sounds like we have 38 patients in the ICU in Minnesota with COVID-19. So the Department of Health has also put this new graph, which kind of you know, categorizes likely exposure, and I think it's notable that about 31% is estimated to be community transmission. So there's definitely community transmission happening in Minnesota. So here at Allina, as of, I believe, last night, there were 2,400 negative tests, 116 positive tests. That gives us around a 4 to 5% positivity rate, and there are 418 pending tests still. And kind of an update on our testing. I know this is kind of a question that we keep, you know, getting asked, and things are kind of changing day by day. So in Allina, I believe that the lab is still kind of doing the model where we are looking day by day to see which of the testing sites has the quickest turnaround. It seems that we are most commonly now using Mayo and MDH rather than LabCorp. And for what I'm seeing is the turnaround is anywhere from around 2 to 5 days. Once again, we are hoping to have in-house testing here by the end of April. So that is something to look forward to. So now I'm going to go through a couple of cases. So we'll start with case 1. So we have a 72-year-old female with a history of hypertension and hyperlipidemia, admitted with weakness, just not eating well, and having some diarrhea, which started about 9 days prior to admission. when you really kind of push her, she endorses that maybe she did have a little bit of a mild cough a couple of days ago, and she is kind of feeling achy with some myalgias. Of note, she did attend a group function about 12 days prior to admission. And so on presentation, she is afebrile, blood pressure is okay, heart rate's okay. She's actually satting pretty well on room air. Lungs are clear. She's a little tender on her abdominal exam. As far as her labs go, a little bit hyponatremic, LFTs are normal. She does have a bit of a leukopenia with a lymphocytopenia. CRP is a little elevated and ferritin is just a touch elevated as well. As far as her imaging goes, so on her chest x-ray, relatively clear chest x-ray, maybe some kind of, hazy infiltrates in the bases. And then her chest CT, that's a little more telling. She kind of has these, as we had kind of gone over previously, these kind of peripheral ground glass opacities. These are actually pretty subtle. And once again, she had really no respiratory symptoms other than a cough that she had kind of had a couple of days ago that had really resolved. So at this point, she wasn't started on hydrochloroquine or antibiotics. She's very stable, just really being admitted for weakness and just not feeling well at home. And here comes her positive COVID test. And so she is COVID positive. During her hospitalization, she does get a little febrile to 100.7, but actually did pretty well. Didn't require any supplemental oxygen. Symptoms really improved. She worked with PT, was able to eat a little more, and energy definitely got better. And so this is just one case that I wanted to talk to everybody about, kind of focusing on kind of GI symptoms. So she really presented with primarily, GI symptoms, the diarrhea, a little bit of abdominal discomfort, anorexia. And so this was a study that was published in the American Journal of Gastroenterology just a couple weeks ago, looking at a cohort of Chinese patients. And actually, it seems like GI symptoms are potentially more common than we thought. And so here you can see out of the patients, about 84% had anorexia, about 30% had diarrhea, about 8% with vomiting, and about 4% with abdominal pain. And something that is interesting is when they then kind of categorize these patients into mild, moderate, severe, or critical, patients who had severe or critical disease, a larger percentage of those patients had GI symptoms. So, the question is, could potentially GI symptoms, portend, that these patients might do more poorly? Unclear, but this is just, I thought, an interesting case that wasn't quite classic COVID, and she really presented with GI symptoms. So something to keep an eye out for. Case number 2. So this is a 65-year-old gentleman with a history of AFib, OSA, hypertension, who was seen at urgent care about mid-March for a day of cough, fevers, and chills after he had returned from overseas the day prior. It seems like his vitals were stable at that point. He was actually, breathing okay. His PCR was sent and was positive, returned a couple of days later. But since he was stable, he went home and was quarantined at home. And it sounds like he actually did pretty well until about 2 weeks later when he presents to the ED with kind of uptrending fever curve, is pretty confused and is dyspneic. He is febrile on exam, hypertensive, tachycardic. He is tachypnic, and he is actually pretty hypoxic, SATs 81% on 6 liters nasal cannula, and then progressed very quickly to intubation. His exam is noted as having diminished lung sounds, and he was indeed lethargic, confused, and diaphoretic. As far as labs go, he does have a bit of an AKI, creatinine 1.54, a little hyponatremic, AST is slightly elevated. Once again, lymphocytopenic with an elevated CRP and markedly elevated ferritin at 12,000. This is his chest x-ray, so as you can see, kind of has these kind of fluffy bilateral infiltrates here. And as this patient is in the hospital, it was decided not to give him hydroxychloroquine. I'll talk about that a little bit later, but basically, the thought is that potentially once these patients get to this point in their illness, 14 days in, we're not quite sure how active the virus is as far as, is there ongoing replicative virus that's causing the pathology, or is it this kind of immunopathology that I had kind of talked about previously with the cytokine storm? He was started on antibiotics for possibly a secondary bacterial infection and did require ARDS cares with proning and Flolan. And so I think kind of the takeaway from this case is these patients can decompensate really late in their illness. And so this is a guy who presented initially with kind of just mild symptoms, was COVID positive, and then, about 2 weeks later, really decompensated with ARDS. And so this is a study from Lancet where they kind of chart out how patients, survivors and non-survivors, kind of did as far as their symptomology and what the timing of their symptomology is. And as you can see, for survivors around day 10, that's when these patients developed ARDS, and then for non-survivors, day 12. And so definitely these patients can initially do okay and then can decompensate relatively late in their course. Once again, theory is potentially that at this point there's some kind of a pathologic immune response that's happening that's causing the ARDS and the decompensation. So, beware late decompensation in these patients. Case number 3. So we have a 54-year-old male with a history of asthma, seen at urgent care in about mid-March for some cough, fevers, after he had returned from a cruise just a couple of days previous. At urgent care, was again doing pretty fine. Vital signs were stable. He had a COVID and a flu sent off, and he was both COVID and influenza A positive, so really unlucky. He was given a course of Tamiflu at home and was doing okay until a couple of days later when his shortness of breath worsened and he presented to the ED. In the ED, he was febrile, he was tachycardic, and he was tachypnic and hypoxic, did require about 4 liters of supplemental oxygen via nasal cannula. On exam, he had crackles bilaterally. As far as his labs go, once again, a little hyponatremic, AST a little elevated, lymphocytopenic again, with an elevated CRP and actually a normal ferritin. Chest X-ray, kind of has these, kind of bilateral infiltrates, mostly in the lower lobes. And so this patient, again, was not started on hydroxychloroquine, just kind of given the, initial duration of his symptoms. And he initially did okay, and his oxygen requirements were actually coming down until about hospital day 4. We had worsened cough and dyspnea. And needed additional supplemental oxygen and had a kind of new fever. His chest X-ray kind of showed progression of his infiltrates. So at that point, he was started on ceftriaxone for possible bacterial pneumonia, secondary bacterial pneumonia, with initially good effect on his cough and dyspnea. He was feeling a little bit better, eating a little bit better, stable on 3 liters, feeling okay. And unfortunately, on hospital day 10, was found unresponsive in his room. Pulseless. A code was called. He had CPR done by a nurse who found him, and had the Lucas applied, was intubated, and was found to actually be in VFib, and did achieve ROSC after defibrillation, was moved to the ICU and did require inotropic support. At that point, had a lactate that was elevated to 6.7, unsurprisingly, and had an echo with an EF of about 40 to 45%. I believe that he didn't have a previous echo anytime recently, but basically at that point, there was concern for potential viral cardiomyopathy in this patient. So I just kind of wanted to go over cardiovascular manifestations of COVID-19 because it seems that COVID-19 might have kind of some tropism for the heart. And so it's estimated that potentially about 20% of patients that are being hospitalized with COVID-19 could experience heart failure. Arrhythmias and shock are something that we are potentially seeing in these patients as well. With acute cardiac injury kind of occurring anywhere between 7 and 22% of hospitalized patients, we're not quite sure exactly what the mechanism of how this is happening is, whether or not it's direct injury from viral invasion of the cardiac myocytes, or if it's just kind of indirect injury kind of due to the stress cytokine mediated, some stress mediated cardiomyopathy or demand ischemia. So I think takeaways from this case is, beware viral cardiomyopathy in these patients. One thing that I did want to mention when I mentioned the elevated lactate is I know, we have our sepsis screen currently, and one thing that I wanted to mention in these COVID patients is they might trip the sepsis screen and their lactate might come back elevated. In a lot of these patients, we are finding that we really don't want to fluid overload them. So I know initially, the kind of our, your initial instinct is to give these patients fluid. I would be very mindful of giving these patients fluid because potentially by overloading them with fluid, there is some evidence that potentially we're seeing kind of, higher oxygen needs and kind of worse outcomes from a pulmonary standpoint. So that's just kind of one thing that I did want to mention. And then another very, very important thing, this patient had CPR initiated by the nurse who was seeing him very bravely. But I want to caution that CPR is an aerosol generating procedure, and before you start CPR or chest compressions on a patient, that you do need a respirator. You need an N95, a kappa or PAPR before administering CPR. So really important to think about our safety as providers so that we're able to take care of patients. So kind of an important point there. So next, I kind of wanted to talk about asymptomatic transmission, because I know there's a lot of questions about this that we're getting. And so basically, there's a lot we don't know. And so the prevalence of asymptomatic and or maybe pre-symptomatic infection is really not well understood at this point, given the fact that our testing is very, very limited at this point. It has been found that actually as many as 13% of PCR confirmed cases in children were asymptomatic. And there was a case of some nursing home residents that were infected from a healthcare worker there, and actually half of those patients were asymptomatic or pre-symptomatic at the time of contact tracing and had a positive PCR. So we think that potentially there is some asymptomatic or pre-symptomatic transmission that occurs. The thing is, we're not quite sure how much this actually contributes to general transmission, and it is thought that likely the risk of transmission is probably greatest when patients are symptomatic. And so we know that viral RNA shedding is greatest at the time of symptom onset, and then after that declines over the course of several days to weeks. So we're not 100% sure when patients seem to be kind of most infectious. It seems to be likely when they're actually symptomatic, but there's still a lot of studies that need to be done as our testing capabilities hopefully increase, where we can kind of figure out how much of a contribution asymptomatic or pre-symptomatic shedding is having in the community. So another thing that I wanted to talk about is prognosis of COVID-19 in the United States. So previously, up until the past kind of week or so, a lot of our data had been coming out of China and Italy, kind of not unsurprisingly, because they definitely had been seeing cases far before we had, but we are getting some data out of the United States currently, most notably out of Seattle. And so this is a New England Journal article that just came out a couple of days ago, looking at COVID-19 and critically ill patients across 9 hospitals in the Seattle region. And so of these patients that they looked at, there were 24 patients. The mean age was 64, 63% were men. The mean duration of their symptoms prior to admission was about 7 days. And of these 24 patients, 12 died, so about 50%. Of note, 4 had DNR orders prior to admission, and then 6 had DNR orders during the hospitalization. Of these 24 patients, 18 required mechanical ventilation, and of those patients, 9 out of the 18 patients who required mechanical ventilation died. They didn't comment on what number of those were potentially DNR or not, so I can't comment on that. But I just kind of did want to go over this because this is kind of some of our first US data. This seems, and it's a small sample, but it's a little more optimistic than some of the data that was coming out of China and Italy as far as kind of what the mortality was when patients were intubated. I was seeing estimates anywhere between 70 and 90% mortality once patients were intubated. So I think we still have a long ways to go. There's still a lot of data that needs to come out of the US, but I'm hopeful that, our mortality rates will be better. And so I wanted to go over treatment as well, because this is something that I think a lot of us are getting asked about, certainly as an ID doc, I am, and then I'm sure you all are as well, from both patients and family members, because we're seeing a lot of this in the lay press, and we're seeing kind of a lot of this across the political landscape as well. And so I wanted to stress that no therapy has been proven to treat COVID-19 in humans. So supportive care is really the cornerstone to therapy here. There are multiple clinical trials that are ongoing, some in China, and then there are definitely a lot in the United States. And of the medications that we potentially have in our toolbox, availability is a concern. So first, I'm going to talk about hydroxychloroquine because, I think that's probably, the most common medication that's being mentioned in the press. And so hydroxychloroquine and chloroquine. So there is in vitro data that demonstrates that chloroquine can inhibit the COVID-19 virus. So basically the theory is it's a mild base, and by, it can kind of affect viral binding and viral traffic in our cells. So it kind of makes sense from a mechanistic standpoint. And once again, there is this kind of in vitro data. But as far as kind of human studies, there's really limited data. So there was this non-peer-reviewed Chinese study, which is really just a letter that was published, claiming chloroquine superiority to standard of care in inhibiting the exacerbation of pneumonia, improving lung findings, imaging findings, and promoting a virus negative conversion and shortening of the disease. And so as of yet, I haven't actually seen that data. It was just a letter that said that data was forthcoming. And so because of this, was hydroxychloroquine and chloroquine was included in the Chinese guidelines and the Italian guidelines. Just a couple of days ago, actually, a non-peer-reviewed Chinese randomized control trial came out. And so basically what they did is they took 62 patients with COVID-19 and randomized them to standard of care, which is basically just supportive care, versus standard of care with hydroxychloroquine for a course of 5 days. And the endpoint was, there were a couple of different endpoints. Endpoint number 1 was normalization of fever. Endpoint number 2 was cough relief. And endpoint number 3 was change in CT findings. And so it was found that for endpoint number 1, normalization of fever, apparently the hydroxychloroquine patients had fever recovery sooner, 2.2 days versus 3.2. As far as kind of a cessation of cough, hydroxychloroquine patients had a recovery sooner, 2 versus 3.1 days. And then changes in CTs, it looks like hydroxychloroquine patients at day 6, 80.6% of those patients had improvement in their CT findings, and about 55% of standard of care patients had improvement at day 6. Of note, of the 4 patients out of these 62 that did progress to severe disease, all of those patients were in the standard of care. None of them were in the hydroxychloroquine, but of the two patients in the hydroxychloroquine arm had adverse effects. And so this is, so basically the conclusion is hydroxychloroquine possibly might have some effect on symptoms and radiographic findings in COVID-19 patients. This is a very limited study. It's a very small study. It is not powered for efficacy, and it really, they didn't really kind of comment on other comorbid conditions that these patients had. And once again, this is not yet peer reviewed. We're seeing a lot of data that's coming out, and because of the pandemic and kind of the urgency, we're seeing a lot of data that's not being peer reviewed and is being released very quickly. And so that's just kind of something, whenever you see data come out, I think kind of being critical about it and kind of figuring out whether or not it's peer reviewed, is something that we need to kind of consider. And so basically, bottom line is hydroxychloroquine might be active. One of the things that we're not quite sure is ideal timing. And so I kind of alluded to earlier, we seem to think that there's kind of these 2 phases of the illness. The first phase of the illness where you kind of have this viral replication, and then the second phase where you kind of have this immunopathologic response, and that's what we kind of hypothesize these very, very ill ARDS and multi-organ failure patients are kind of in that second phase. And so the question is it helpful to give these patients in the second phase hydroxychloroquine, or would it be better to give it to them in the first phase when they're not that sick? We're not quite sure. One thing that I will comment on, I'd mentioned earlier that COVID-19 patients can have very severe cardiac manifestations. I really think it's important to consider QTc prolongation in these patients as a result of hydroxychloroquine. And that's something that we've actually already anecdotally seen here. So I really, I don't think hydroxychloroquine is a silver bullet. There's a lot of research that's ongoing, and I do think that potentially there could be some adverse effects with it. So I think it's something that data is, the jury is still out on. I also wanted to talk about hydroxychloroquine and azithromycin because I think that's something else that we're seeing kind of in the lay press. And so basically there's one physician in France who is doing these hydroxychloroquine azithromycin studies. His name is Dr. Wout. He's an MD PhD specializing in infectious diseases. And so his lab has produced 2 studies. And so the first study that I think we all kind of heard about and kind of prompted a lot of tweeting and a lot of kind of press surrounding it was peer-reviewed very quickly within 24 hours and was published in the International Journal of Antimicrobial Agents. And so what it did is it looked at 36 COVID PCR positive patients. And so They didn't randomize these patients. They basically gave the patients a choice what arm they wanted to be in. And so they gave 20 patients hydroxychloroquine and 16 patients got standard of care. Unclear why, but it sounds like of the hydroxychloroquine patients, 6 out of 20 got azithromycin in addition to it to prevent bacterial superinfection, is what it said in the study. Kind of unclear beyond that why they did that. And then one thing that's really important to note is so initially there were 26 hydroxychloroquine patients with a total, so meaning a total of 42 rather than 36, but 6 of these patients who were getting hydroxychloroquine were actually removed from the study due to early hydroxychloroquine cessation. So they were not included in any of the analysis. And 3 of these patients transferred to the ICU, 1 died, and then 1 stopped secondary to nausea. And so, I think that's kind of important knowing that these patients were not initially kind of included. The endpoint also is kind of unclear if it's useful, which is the clearance of virus from the nasopharynx at day 6. So basically a negative PCR. Unclear if that's really clinically important at this point. So of the patients who got standard of care, it sounds like 12.5% of those patients had viral eradication versus 14 out of 20, so 70% of the patients who got hydroxychloroquine had viral eradication at day 6. And kind of this weird little subgroup of patients who got both hydroxychloroquine and azithromycin, they had 100% viral eradication. So I think, a couple of issues with the study. So, one I think is, is viral clearance meaningful endpoint from our point of view? I really don't know. There were confounding variables. So of note, everybody who got hydroxychloroquine was at one hospital and patients who didn't were at other hospitals. So, that's confounding. It wasn't randomized. So once again, patients were able to kind of choose to serve as a control or treated. And then also they were using different PCR tests. Some were qualitative and some were quantitative. So definitely not a perfect study. There was a second study that just came out a couple of days ago, not peer reviewed, published on a website. And it's basically a single arm observational trial looking at patients who received both hydroxychloroquine and azithromycin, 80 patients who were PCR positive. These patients were not that sick. So only 15% of these patients had a fever and only 50% of patients had a lower respiratory tract infection. These patients were all hospitalized. Why they were hospitalized, I'm not quite sure because they honestly, didn't sound that ill. But, this was a generally mildly ill population with, once again, the endpoint being clearance of, the PCR from the nasopharynx. So how clinically significant, unclear. 83% of these patients who got the therapy were negative at day 7, 93% were negative at day 8, but this is observational, single control, and single arm, no control. And, we're also not quite sure, like, it's possible that these patients would have cleared anyhow at day 7 or at day 8 without therapy. So these are the studies basically that we have for hydroxychloroquine and azithromycin. So if you're getting asked about it from patients or from families, this is the very imperfect science that we have for it. I would argue that we should not do this, and the science is definitely suspect. I think there is a real concern for QTc prolongation in these patients, so I would tread very carefully. And then also I think it's really important that we need to acknowledge antimicrobial stewardship during this pandemic, and so just using antibiotics, is something that I think we need to really consider. So that's that. We'll kind of run through quickly a couple of other treatments of unknown efficacy. So remdesivir. So this is an antiviral that has showed activity in the past against MERS, SARS, and Ebola. Currently, so it is made via Gilead. Initially, there was availability via compassionate use. However, they are moving over to expanded access, and we are working as a system to be able to become an expanded access site. This is all ongoing, and the paperwork is in process. So we are hopeful that we will become a site, but currently we are unable to obtain it, other than for pregnant women. That is kind of the one group that Gilead is still offering for compassionate use. And there are across the United States multiple randomized control trials that are ongoing with remdesivir, lopinavir, ritonavir. So this is an HIV medication, a protease inhibitor. It was recommended in the Chinese guidelines. However, there was a trial just a couple weeks ago published in the New England Journal of Medicine, which was an open label randomized control trial and showed no difference between lopinavir, ritonavir, and placebo in mortality, time to clinical improvement, improvement or viral clearance. So we're not endorsing that. Convalescent serum. So this is actually a really intriguing thought, and it's an old therapy. And so basically the thought is patients who have recovered, you take their serum, and in theory they have made antibodies, and you use that as therapy for patients who are sick. There are a couple of universities across the United States that are looking into this and are doing studies. It is an intriguing therapy, but we are not currently offering it at Allina at this point. There's some question as to whether or not immunomodulators might be useful in this disease, especially at that kind of secondary phase where we're seeing patients kind of have that immunopathologic response. And so tocilizumab is kind of the big treatment that we're hearing about, and that we do have some tocilizumab doses at Allina. What it is, it's a monoclonal antibody against IL-6 that is used in rheumatoid arthritis. And so IL-6 is a cytokine that is thought to be be very important in what we think is the cytokine storm in COVID ARDS. Is recommended in the Italian and Chinese treatment guidelines. There are clinical trials that are ongoing looking at tocilizumab as well. And then kind of unclear efficacy of, role of steroids or IVIG. As far as our treatment guidelines, so they're available on the AKN. And so basically what we have here is we have hydroxychloroquine and we have few doses of tocilizumab, and they are restricted to ID and the intensivists and pulmonologists. And so basically we have a kind of a flow sheet here. And so basically if patients have suspected COVID and they have infiltrates or are requiring supplemental O2 and are ventilated, we're saying initiate the remdesivir process. But I do want to say that right now we're kind of in this weird in-between period where we can't really get remdesivir. So hopefully we'll get to a point where we will, and that'll be the process. But right now we're kind of holding off on this. And consider hydroxychloroquine for these patients. And so I would recommend, if the intensivists, they're taking care of these mechanically ventilated patients, they're able to do it. Otherwise, consulting ID is definitely, not wrong and something that, we encourage. If the patients are not mechanically ventilated but are requiring supplemental O2 or seem to have a pneumonia with infiltrates and are positive, PCR positive, we're saying contact ID, and we'll consider treating with hydroxychloroquine. I would say if their PCR is pending, if it's one of these patients who, we're having for some reason a longer turnaround and you're concerned, you can also feel free to contact ID, and it's something, we can potentially on a PCR positive patient who we think might benefit. I think it's something we can definitely consider. We're also considering treatment for patients who maybe don't have a pneumonia and aren't on supplemental oxygen, but have COVID PCR positive and are at high risk severe infection, potentially treating those patients. So these are patients you can see kind of down below, patients who are elderly, patients who live in a long-term care facility, patients who have lung disease, heart conditions, immunocompromised patients, obese patients. So that's another group that we're definitely considering. And so once again, we're meeting with the ID task force every week. This might change week to week, so I would encourage checking on it week to week, because as new data is coming out, we are trying to update this as quickly as we can. And so I also wanted to talk a little bit about immunity, because I think this is possibly how the pandemic ends. And so humans have demonstrated antibody responses to the coronavirus, and there are commercial assays that are being developed currently. We don't have access to that, but they are being developed across the United States. And so actually in the Lancet, there was a paper that was just published as a preprint a couple weeks ago, looking at antibody responses in patients who have COVID. And so as you can see here, they basically checked kind of serial RNAs and then total antibody IgM and IgG over a course of time from day 0 to day 40. And 100% of patients did develop total antibodies against the coronavirus, which is encouraging. I think the question is, how durable is this immunity? And that's something that we don't really know yet. And so it's notable to say that kind of the first SARS patients had 8 to 10 years of immunity. MERS patients, which is another coronavirus kind of similar, these patients only had 1 to 2 years of immunity. And then our common cold coronaviruses, it seems that we probably only have about 1 to 3 years of immunity. And so we're not quite sure which category we're going to fit in here and how long our immunity is going to be, if it's going to be durable immunity or if it's going to be brief immunity. It certainly has implications for herd immunity, and it has implications for vaccine development. There's another question as far as, if you do have immunity and it does wane over time, do you have enough to kind of blunt the disease? And so there is a theory that potentially that's maybe why children are spared, is because they get these kind of coronaviruses, these common cold coronaviruses over and over and over again. And so potentially they have kind of this cross immunity that is enough to kind of blunt the disease. So they're not really symptomatic with COVID. So a lot of questions, a lot of research is happening right now. And I think we definitely at this point, more questions than answers, but it is definitely something that is being looked into. And then, I think the question is, can we potentially get reinfected as well? And so there is a group of non-human primates that are being studied currently for reinfection in China. And so basically what they did is they took 4 rhesus macaques and they inoculated them intratracheally. They sacrificed one of them, and then one was control, and then the other 2 were then re-challenged at day 28. Initially, they're presenting symptoms with COVID were basically weight loss and fever. And so after they were re-challenged, it sounds like the 2 monkeys that were re-challenged had a kind of a transient elevation in temperature, but did not have any weight loss. And then they also looked at their viral loads, and you can kind of see that on re-challenge, they did not have detectable viral loads, which is encouraging that, potentially there may not be reinfection. And so they're still following these monkeys. And so it'll be interesting to kind of see what happens over time. All right, so a couple notes on universal masking. So as I'm sure everybody has heard, we instituted universal masking here at Alina on the 31st, both to conserve PPE and to increase protection for patient-facing staff, as we are kind of starting to see some more community transmission in Minnesota. Employees are issued 1 mask to be used until it is visibly soiled or worn. And then isolation units in the ED, ICU, and cohorting units are getting, staff there are getting N95 masks as their reusable mask. But kind of in the context of this is kind of different than kind of, day-to-day PPE. And so our isolation precautions have not changed. So patients who are getting aerosolizing procedures, need airborne precautions with the respirators, and then patients who are not getting that are having enhanced droplet precautions. So that is not changed. And we wanted to let everybody know that there are videos that are available online on the AKN that were just updated, that videos that go over the reuse of N95 masks and the reuse of ear loop and surgical masks, because I know there are a lot of questions about that. So beyond that, kind of remember the following points: that you do need a face shield that covers the mask for any COVID or PUI patient, because in theory you would not want that patient to cough on your mask and have that become contaminated. The shield should cover the mask and kind of preserve the mask from being contaminated. Please reuse the masks until they're visibly soiled or damaged. I think something that's really, really important though is make sure you're doing excellent hand hygiene. So before you touch the mask, wash your hands, use use the alcohol-based cleaner, and then after you touch it, do the same thing. And this is something that is also kind of changing. We're kind of updating PPE and all of these guidelines as time goes on. And so always look to the ACAN for the most up-to-date information, as this is all changing very rapidly. So a couple take-home points that we'll talk about. In Minnesota, we are seeing an increase in cases, and there is an increase in community transmission. As far as kind of clinical presentation of these patients, beware late decompensation, and then also think about GI and cardiac manifestations in these patients. For ACLS, if you are doing CPR, you need to be wearing, an N95 cap or PAPR. Asymptomatic transmission can occur. We're not quite sure to what degree. Hopefully we'll know that, as testing becomes more available over the next, few months. I wanted to let everybody know treatment guidelines are available on the AKN. There's no proven pharmacological therapy for COVID-19. Things are being evaluated. If you have any questions, feel free to call ID. We're happy to kind of, walk people through it, answer any questions you have. We're hopeful that we have immunity after this. It seems like evidence is showing that we do. The question is just how durable that is. And then universal masking has been instituted here, so everybody get your mask.
Great. All right, thank you so much, Dr. Lanosa, Dr. Bradley. We have about 50 questions to go over, so we will do our best to get through some of the ones that were most commonly asked. I'm going to let Dr. Bradley answer some that are specific to him to give Dr. Lanosa just a second to breathe. So the first question is about, can you comment on the difference between the Gates University of Washington data versus the University of Minnesota data?
Yeah, so I note that the question says the University of Minnesota model is not publicly available. My understanding is the University of Minnesota model is more of a traditional SIR model, susceptible, infected, recovered model. Regardless, they both suggest that the peak is coming in the next 3 or so weeks. And I guess I should clarify, when we say peak, there's kind of two components of peak. Peak is when the most patients are infected. There's also peak in terms of hospital utilization. It's anticipated we'll kind of achieve our peak capacity within the hospital in around 3 weeks, but then we'll probably maintain that for quite some time, on the order of potentially months, regardless of which model you look at.
Okay. And then the next one, since you're a cardiologist, I'm going to throw them to you, but the question is, my understanding is that we're trying to avoid stenting in end-STEMI COVID patients and just trying to do medical management. Given the cardiovascular manifestations, should we be stenting these folks like usual? Yeah,
I think that's a great question. So I think it's important to differentiate the concern for COVID cardiomyopathy, which is viral implication for the myocardium and the muscle, versus atherosclerotic cardiovascular disease. There's not current evidence to suggest that it contributes to atherosclerotic cardiovascular disease. So our evidence suggests that stents are really most beneficial in STEMIs and higher risk non-STEMI, so unstable non-STEMI. The mortality benefit for stents in essentially stable non-STEMI is pretty small. So I think it's not unreasonable for us to think long and hard about the COVID positive patient and the risk benefit trade-offs, exposure to our hospital providers, what it means for additional patients who will be in that room next as it relates to stenting for COVID positive patients. I will add, for the STEMI population, there's a lot of thought about moving towards fibrinolytics for a COVID positive patient. I think given the more we understand about troponin elevation, potentially reflecting something other than acute myocardial infarction, that we may move away from that and still think about traditional coronary angiography and PCI for patients with STEMI, because that may actually be diagnostic that the EKG changes in troponin aren't from coronary disease, but from COVID cardiomyopathy.
Great. And then one that's just kind of a more general question, but should all COVID patients in the hospital be on telemetry?
Yeah, I think that's also a very challenging question, given the concerns that were raised about QTC prolongation. I think one of the things we also have to think about is how do we work in an environment that's different than anything we've ever experienced before. Very soon, we're not going to have the ability to put telemetry on every patient by any stretch of the imagination. So we need to think about a smarter way of doing that. That's part of the role of the Healthcare Delivery Innovation Center, to trying to leverage our data to identify who are the patients who are at risk that would benefit from tele, but I would not recommend tele for all patients at this time.
All right, and then one last question, cardiology related, is should every COVID positive patient get an admission bedside echo? Hopefully we're talking about POCUS, so point of care ultrasound, not formal, to assess for possible cardiomyopathy. Should serial bedside echoes be followed?
Yeah, so I think there's a couple things to clarify here. The data that have talked about cardiac injury are based on troponin only. So when they talk about a 40% prevalence of cardiac injury, that's based on troponin. That is not specifically for cardiomyopathy. The rates of cardiomyopathy appear to be quite low. So no, I would not recommend an echocardiogram on every patient, number one. Number two, that's part of the reason we've avoided getting, at least initially, a troponin on every patient, because we did not want to reflexively result in patients getting echocardiograms that weren't going to change their management. We may, again, need to rethink about who are the patients for whom that's beneficial, but currently, no.
And then I'll just say that on the webinar tab on the AKN Provider Resources page, I just had a new webinar uploaded by Dr. Dave Tierney, who's the point of care ultrasound national expert out of Alina. And so please, if you have any interest or ability to do bedside ultrasound, please look at that. It's a 30-minute video mostly about lung, but also I think touches on a little bit of echo as well. Okay, Dr. Lanas is back up, or Dr. Anderson is in the room as well. There's a question about a timeline on a test for immunity and how we might be using.
I mean, I had seen that Mayo is developing a test. I'm not quite sure if it is going to be available to us. I don't have a good answer for that. You know, I would hope in the next few months, but unclear. Good question, but unclear.
Okay. The next one, will we be adding GI symptom screening to any of our screening questions for patients or employees? I think that we had Epic as a company had added a few new symptoms. I think that that's coming out in the next week or two. I do not believe that GI symptoms are one of them. The concern was that if GI symptoms were the only positive symptom, that the screening would be just screen. Everyone would fall into that category, especially since abdominal pain and presenting symptom isn't for ER patients is so common. So I think the answer is at this point, GI symptoms are not going to be added to the screening questions for patients. I can't comment on the employees. There's another question about if cases continue to increase in Minnesota and more ICU beds are needed, do we have a plan to use stadiums? Who will staff this? And how do we mobilize other practitioners, including physicians and APPs? That is a bigger conversation amongst the Department of Health and other coalitions within the state. But yes, I think there have been rumblings about using other larger facilities. As far as the staffing plans, I can't comment at this time. Another question about in the ER, we're seeing more gray zone patients. So that's what I believe Mercy is using to try to create these contamination zones and keep non-COVID people away from possible COVID and confirmed COVID. So they're seeing more gray zone patients than obvious COVID or non-COVID. Where should they be admitted? If I'm concerned that many of these without definitive symptoms will turn out to have COVID and may be on the non-COVID floor. I'm going to leave that to the ID docs to answer.
That's a very good question. It's difficult to answer because part of it depends on the individual geography of an institution, the staffing, and it's not, so many things go into that. One is the consequences of labeling a person as a PUI or person under investigation triggers extra use of PPE. If they get admitted to a COVID cohort unit, that can fill up a cohort unit. I don't have a good answer to that question other than each institution needs to think and rethink daily and adapt depending on the prevalence of the disease, how many people are coming through. It's a very good question, but the answer can change.
I think that prevalence of disease component is critical. I think, so we've been reviewing the individual cases, and I think if you have a patient with vague symptoms, but they're in a group facility where somebody has recently been diagnosed with COVID or symptoms consistent with COVID, that changes the math entirely. But if they're relatively isolated, elderly patient who has other reasons why they could have those symptoms, it tends to be that it's not at this point. That will change as the prevalence of COVID changes, though.
All right, we'll do 2 more questions. What is our current ventilator situation for Alina in Minnesota? How many do we expect to need? Do we have an ethics policy in place for Alina in case we do not have enough ventilators necessary for our patients? So I can speak that across Alina within the anesthesia Alina-wide group, they are actively doing inventories of all of our anesthesia machines, our ventilators, other possible resources like outpatient surgery centers that might be willing to lend us anesthesia machines. I believe there's work on a Minnesota-wide anesthesia level as well. And then yes, there is an ethics policy called the Scarce Resources Policy that was solidified a couple weeks ago and now is in the process of getting what are called triage teams. So teams of nurses and physicians who would be the people following a process to figure out if a scarce resource was appropriate on a patient-by-patient basis. The last question we'll do, and I think is an important one, is are there any recommendations for how to minimize exposure to family at home when we come home at night with regard to quarantine, isolation, or social distancing?
So I mean, there haven't been any kind of guidelines released, to a wider population of healthcare workers. I kind of mentioned it last week. The CDC has a webpage called Clean and Disinfect, which is intended for patients and patient families of COVID positive patients. And so I think potentially you could extrapolate out from that. And so basically they're recommending, cleaning all of your clothes as soon as, you're getting home, and, using a detergent and, your hottest wash possible, being really aggressive about, keeping everything, clean, wiping down surfaces, and just kind of practicing, good hygiene in general and social distancing kind of where you can. I think, I know it's, a really important question and, we all want to keep our families safe. And, hopefully we'll have some guidance in the future, but right now I would say just kind of out of an abundance of caution, being as, clean as you can, washing your hands very frequently, keeping things at home, wipe down, washing your clothes as soon as you get home. I've heard some people are showering as soon as they get home. I see nothing wrong with that. I think until we have a better sense of exactly, how this is transmitted, what the frequency of asymptomatic transmission is. It's a good question.
Great. Okay, thank you everyone for attending. We had over 300 people watch this live, so that's amazing. Thank you for taking the time to educate yourselves about this really rapidly changing process and the guidelines. And I know it's frustrating when things change so rapidly without maybe some clear explanation behind it. So hopefully this provides a lot of that evidence or lack thereof that we have about this, and explains some of those studies in better detail. So thank you again. We will do this next Friday. If you have any burning questions or kind of like bigger topics that you want seen, please feel free to email me. My name is Sarah Preble, and you can find me on the Alina email. Otherwise, this will be recorded and on the Alina YouTube channel for public use as well. So thank you so much.